So next part, so we had a very nice introduction on the anatomy and physiology, a bit of an introduction on some of the vestibular disorders always by Herman. So the next step, in fact, in this talk, and of course in the central vestibular disorders, it will go on in the central nervous system, is how to use this information in clinic, because our patients are, of course, not aware of it. So they are, until they have these symptoms, as mentioned before, they have no realization that the vestibular system is something that exists. So this is very important, how to integrate all this knowledge and be able to use it and apply it to our patients and provide good care. So the word provide is a very well-chosen word for this consortium, how to integrate all the knowledge that will be generated and actually provide some improvement in the care at a daily level to our patients. So I'll bring you a little bit in a short version on what are the different peripheral vestibular disorders, how we manage them in the clinic, because it's often very difficult for us because we only have a short time to make a diagnosis in our patients, and also share some of the challenges in how to treat patients and provide like an evidence-based kind of management for them. We've had a nice introduction of the system I love so much. So this is something, of course, very important, anatomical situation of the vestibular system, and of course the cochlea for hearing, but also the facial nerve, which all comes down to around 2 centimeters that this organ is situated in. So it makes it very difficult, in fact, to do any kind of surgery on this. So we do, of course, balance system surgery like on the semicircular canals, but then, of course, we want to make sure that we don't lose hearing. The other way around, if we do a cochlear implantation, we can lose vestibular function. And of course, the facial nerve is just wandering around, and we're trying to avoid it during surgery, but also it's an inherent risk. And there's also some variations in anatomy, of course, because it's not always like that. There are some ranges, but still in surgery, this can be quite a challenge. So this is something that's very important when we provide any kind of surgical solution, that we have a profound knowledge of this anatomy in a patient when we operate on that. And it's also something that, going back to this is something that we provide to our patients. So we have flyers in the outpatient clinic where we give them a sagittal figure, a drawing, of the ear, including the ear canal, the eardrum, the vestibular system, the cochlea. So we can draw on it where is your actual disease, where is it originating from, what are we actually trying to reach, so we can explain to them what is happening. Makes it a little bit easier for them to understand what's happening because they think that you're drilling into the brain every two surgery. So very complicated to explain. Okay, so overall, the challenge that we do face is, of course, and this is why the purpose of this consortium is so important, that a lot of incorrect diagnoses are made. So we see that a lot of our patients are in fact suffering for a long time before they get the correct diagnosis. And of course, you only can manage these patients at the very moment that you have a correct diagnosis. So we're not looking at any kind of treatment that will treat all patients. This is not possible, of course. We really want to have a correct diagnosis first, and then we have the correct evidence-based management. Whatever it is it the kind of medication, is it surgery, is it any kind of physical therapy, of course, whatever manages the patient successfully in the long run. We do see that a lot of patients do not know which is the physician I need to contact. So they will start at the general practitioner at the primary care level. This is very difficult because, of course, they have a lot of patients that they have to see. And of course, for the more rare diseases, it's a challenge because they're not aware of these systems. So it's very important that at the medical student level, we provide also the basic peripheral vestibular disorders and other disorders to these people because they are the front line. So these are the first signal, like the first point of contact for patients. So it's very important. And there's a lot of different specialties involved because patients are not really what the fact is if it's related to the balance system. So to give an example, indeed, some patients, like for example with bilateral vestibulopathy, they are just complaining of visual acuity problems. So they think, well, I need to see an ophthalmologist, so for the eye specialist. But of course, these visual acuity testing is static. So they sit in front of this testing device and the acuity is normal. Of course, what these patients have, they have the dynamic visual acuity problems. So then they don't realize, and even the eye doctors don't realize, that maybe we should then test the vestibular system because there might be a bilateral vestibulopathy. So this is very important that the patient doesn't know how to connect the symptoms they experience to the specialty they have to impact. Even for the GP, it can be quite different. So of course, there's a lot of costs. You can imagine that there's a lot of people that not only having an impact on the quality of life, but also an increased risk of falling, then it gets fractures. The cost of then treating these complications, of course, is quite huge. Emergency care, getting hospitalized, getting surgeries to in fact just treat the consequences of these disorders. And of course, these quality of life aspects, they are not counted or costed as much as the direct costing of these consultations. So the impact on quality of life or that you are not able to work, these are indirect costs and they're generally not that thought of in any kind of calculation on the impact of the management. So the cost of the management versus if your patient is no longer busy, whether this is in fact a cost-effective kind of management. This is going to be important, of course, for if we have a vestibular implant. Then the next question is going to be, okay, so we have the cost of the vestibular implant. What's the cost of bilateral vestibulopathy? Because otherwise, if no one realizes this, well, probably that's going to be a huge issue. But that's something we'll take care of. So the cost, in fact, for instance, for the EU, for Europe, has been estimated at around 6 billion euro. So that's a lot of things we can avoid. Of course, mentioning, of course, we are in an aging population, so we do anticipate that by losing some part of the vestibular function along the age, that this problem will be growing. And of course, the cost will also grow because of the likelihood of these falls and also the severity of them. Of course, part of the project is on trying to restore vestibular function. It's something that we at this point cannot not yet offer to our patients. But of course, very important that in unilateral and bilateral vestibulopathy, I think bilateral vestibulopathy, because there the consequences and the impact is of course the highest. That for now we have to manage with the kind of treatments and management options that we have. And of course, also the secondary problem. So we see that a lot of these patients do have chronification of this function, so it makes it a little bit harder. But if they have the symptoms for a longer period, for several months, then you have the impact of anxiety, depression, that will also then increase the intensity of the complex and also makes it a bit more difficult with the usual management like physical therapy to in fact treatment. That's why there's more research into combining physical therapy with like a sort of cognitive training or cognitive behavioral training or explaining and managing the risk factors of our patients. Okay, and first problem is that sometimes patients don't think as dizziness as a medical problem. So that's the first step. If the patient doesn't realize that it's a problem that might be a medical problem that arises from any kind of problem in the brain or in the balance system, if you're not aware of a balance system, of course, you don't go to a doctor anymore. So I think part of this project as well is to try and realize that to make the awareness on dizziness, that is something that you should talk to with your general practitioner, something that is really not something we take for granted. This is also part that we have to think. Of course, whenever the GP is taking care of the patient, whether to refer or not, correct diagnosis, long-term impact, this is something, of course, that are challenges that we will not also solve in the project, but still we have to be practical. Okay. So there's quite a lot of vestibular disorders, and part of them, of course, will be in the next talk on the central vestibular disorders. I've highlighted the disorders that I will talk in this lecture, and this is the QR code. So you can just go to the Brani Society website where there's all these diagnostic criteria. So I think it's very important to us that in the field we have criteria to work with, because often we lack the objective testing for several of these diseases, and then it's very important that we can in fact give a sort of certain or definite diagnosis to a patient based on criteria, and that we're all diagnosing the same type of patients. Also for research, it's very important that if you would do a multi-center study, that we are all including the same type of patient. So this is very important. So I think that if you see definite or probable, the reason why it's definite, we really want to include the definite patients in like clinical studies. So the problems probably to give you like as a clinician the option to diagnose them, but it might be that it's a little bit less strict and might not be 100% sure that this is the correct diagnosis. So for every one of these, there is diagnostic criteria available that are sometimes updated. Of course, some of them have been started. I think Meniere's disease was 1995, and it has been updated in 2015. So this is an ongoing work, of course. So it's worthwhile to keep on checking these criteria, and they're free as well to be accessed. Of course, it's a long list, and what I usually do to make it a little bit less fuzzy is in fact to just categorize them. So generally, it's possible to categorize in three kind of syndromes. Syndrome is like a sort of a combination of symptoms, and you can use the acute vestibular syndrome, like the patients that come in through, usually it's like the emergency room, where they have continuous vertigo or nystagmus for hours or days. You have the episodic vestibular disorders. Usually they go through the clinic, not through the emergency room, not always. And they have episodic, so attacks of vertigo. So it's not continuous, but they have some attacks. It might be triggered, it might be spontaneous, but still there are attacks. And then the chronic vestibular disorders. So patients having these symptoms for a very long time. It's often not spinning vertigo. It's almost never spinning vertigo. But whenever they wake up until they go to sleep, it's always there. So these three syndromes are for very important, in fact, to make it a little bit easier to narrow down your diagnostic landscape, as we call it. So making sure that the list is a bit smaller in potential diagnosis that you have in this particular patient. So we'll talk a little bit more on these different syndromes. And I've put vestibular schwannoma a little bit on the in sort of corner, because as Herman mentioned, maybe it's a little bit different because we see different types of vestibular loss. Sometimes they lose it gradually and they don't notice that there is a problem. Often they have normal hearing, so they don't have any hearing loss. But some of them have like these spells of vertigo where you lose function, but not all of them. And then a few years later, you lose some of the residual function. So it might be a little bit different in the vestibular schwannoma cases. And it's in fact that the disease that patients are afraid of. So patients think, in fact, as shown before, that they are dying. So there must be a breakthrough. So that's often why we do an MRI scan, to make sure that there's no tumor. The majority of cases, of course, the patients want to be sure. So Meniere's disease is something that's, in fact, it's a very short time to explain, but you can narrow it down to somebody that it's a disorder with episodic vertigo, very important, associated with hearing loss, which you can detect on audiograms. Most often it's low or medium frequency sensory hearing loss, and tinnitus because of that hearing loss, and a feeling of pressure in one ear. It can be a little bit difficult because sometimes people have on both sides, but usually it's only one ear, meaning that you really have to narrow down and ask your patient which is the side that you have the symptoms of hearing on, because the patient cannot tell, of course, if it's the dizziness or the vertigo. So which side is in fact the one that's active right now? And this is very important because if you give medication, there's no problem. We don't need to know which side the problem is on. But if you do surgery, it is very important. It's essential to know which side to operate on. So it's a bilateral problem. You really have to base yourself on some part of the history sometimes of these patients. So it can be quite challenging. Pathophysiology, to be a little bit short, and I'm not sure whether this is actually correct, but the general idea is in fact that there's an endolymphatic hydrums. So the endolymphatic fluid in the inner ear is in fact, the pressure is increasing. Probably there's a lot of debate whether that's actually the pathophysiology. For now, we have to think that it's correct, and that's the reason why, of course, this is something that provokes both hearing loss and vertigo spells. There's also always some ideas on membranes breaking, and then the fluids are like mixing. I'm not too fond of that hypothesis, but there's a lot of opinions on that, on metastases. It's also the disease that patients know about, and often they don't have, right? So the diagnostic criteria, so as said, these were in fact the earliest ones, the updated version 2015. It really just gives you an idea of if the patient comes in as spontaneous episodes, so they're not triggered by a vertigo lasting over 20 minutes up to 12 hours. This is like the ideal case, like the definite case. And you also have an audiogram where you have the sensory hearing loss and fluctuating oral systems. And then also always these criteria have these fourth criterion that it's not better accounted for by another vestibular diagnosis, which is of course a little bit an extra challenge to this. So it means that sometimes or often patients match different diagnostic criteria. So you probably can match a patient with Meniere's disease, vestibular migraine, which we'll see a little bit later, but also vestibular paroxysmia, and then it's going to be a challenge. So then we usually make like a top three, like saying, well, I think we have more arguments for that disorder to decide which treatment to go for. Because we need to just offer our patients. So these are the criteria, and that's the definite ones, meaning these are the patients we also want to include if there's any kind of trial that we want to do, but I'll show you later on how things are working with clinical treatments. Just in. So for benign paroxysmal positional vertigo, we've seen a little bit. So this is this displacement of this otoconia. And of course, at this point, the vertigo spells are triggered by head movements in the axis of this specific canal. So this is very important. We'll see probably later on that there's some differences with vestibular paroxysmia, where it's not specifically in the axis of the semicircular canal. Most often it's the posterior canal that's affected. And the criteria are really just matching this kind of history that it should be short. You should, in fact, see the nystagmus when you do a video coloscopy, when you do the Dix-Hallback maneuver. This is quite obvious that, in fact, just match the diagnostic criteria with the actual EBP case. We saw this. This is the treatments. I never found a better view, so I just keep on using it for 10 years. So you see here that this is the posterior canal. You see the head movement in the left upper corner. Fluid is moving. And then you see a huge otoconia that is moving around the posterior canal. That's the reason why, of course, in the head movement, the vertigo is, in that case, triggered, and the nystagmus will stop whenever the otoconia are at the most inferior level for gravity. So we do the Dix-Hallback maneuver. It's a very easy maneuver for patients. It's also a very scary maneuver because they know you will check it, but you, in fact, provoke the symptoms. To just assure them. Here you see that usually we use goggles, infrared goggles, to in fact observe the nystagmus. This is better. It also explains, in a moment we'll show the canals that therapeutic maneuver. So we just need to make sure that the otoconia, they are dislocated. They have to move back to their original position. So that's why we do this maneuver. It also always seems a little bit strange to the patient that this is in fact working. It's working quite well. That you just move them to the other side, make sure that they're on the side, and then they're just in the sitting position. And here you see why it works. So you see that the nystagmus is provoked. This is diagnostic maneuver. Patient will have vertigo. If the patient does not have vertigo, this is a little bit of a challenge. Probably this is not BPPV. And then the nystagmus stops, vertigo stops. They move the head, no vertigo, because they're not really a movement of the otoconia. But then if you move them on the side, this case the left side, then there's movement of otoconia. You see the nystagmus, vertigo is starting again until it reaches the lower point. Then the nystagmus is gone. We try to stay in this position for 1 minute, or at least if the nystagmus is gone. And then the final movement of the otoconia back to the original position in the central part, where the patient can feel some kind of translation sensation. And that's it. It's not more than that. So there has been a lot of debate on whether this effect exists, because it's a little bit puzzling and quite amazing. It's a mystery that you can do this kind of maneuver and that it's able to in fact work. And so in London, Ontario, so in Canada, they in fact excluded, so they removed part of the posterior canal, and then they done some scanning electron microscopy, in fact, to in fact confirm that there is autogonia in the posterior canal. These are surgeries that are performed, in fact, in like refractory cases where we can do whatever kind of therapeutic maneuver, but probably there's too many autogonia, or there's some kind of maybe scar tissue or fibrosis that it's not able to move to the correct position again. So that's one of these cases where we actually can confirm that these autogonia are in fact the actual reason why the symptoms are there. And these are pictures from the type of surgery that is rarely though performed, because often these therapeutic maneuvers are very efficient. But sometimes, like after a car accident or trauma, head trauma, you can really see these autogonia. So you see the part here, the white part. So this is the posterior canal that's opened up, and you see in fact this white debris, so white parts. These are the autogonia that are in fact just making a sort of clot, and then it explains why it's not possible to in fact move it back to the original position, because it's just somebody that's made a sort of conglomerate autogonia and is not able to move down the posterior canal. So this is really something that we think that, well, we know the pathophysiology. Unlike Meniere's disease, there's a lot of debate. Here, I think there's no longer any debate on this specific disorder. It's also the most frequent one that we maybe not see in the ENT department, because we often see the ones that don't work. But it's one of the most frequent. Acute unilateral vestibulopathy is something, of course, that's the acute vestibular disorder. So patients come in, there is a continuous nystagmus and vertigo. There's a lot of challenge, and maybe we'll see a little bit also the central vestibular disorder, whether this is something that is peripheral or it might be in the base, and probably we don't know yet exactly. But for now, we think that is something that probably is happening in the peripheral system, although there is a challenge whether to differentiate it from stroke in the brainstem. So this is very, very important. So that's why in the emergency room, we want to know whether it's potentially a stroke or the start of a stroke versus something that is, in a way, self-limiting, meaning that it's happened, but as long as we have the other system, we can do physical therapy, we know how to manage it, and there's no other symptoms that will arise. Like in stroke, of course, you need to be very careful, or there might be more progression of a stroke. So that's a completely different management. It's beyond the scope. We have quite easy clinical tests to determine this in the emergency room in these patients that we can do in their bed. Just really easy tests to differentiate whether there's an increased chance of stroke or and you can see, you can read diagnostic criteria, the Brain Society. Of course, in this case, we can do the V8 or the head impulse test, and we'll see that there is one side, in fact, that has a hypofunction, reduced function, or a loss of function that explains the direction of the nystagmus. The direction of this nystagmus is very important in this case to differentiate from stroke. One of the next training schools, it might be better also to dig deeper into the management, but 45 minutes is a bit of a challenge to really do that. So bilateral vestibulopathy, and I'm not talking about peripheral vestibulopathy, which is sort of like halfway when you're aged and you have less function, but it's not lost like in bilateral vestibulopathy. It probably has a similar kind of symptomatology because of the aging and the multisensory deficit. But of course, you've seen the impact of bilateral vestibulopathy, and I think that more parts of the projects are also covering this disease. I think it's very important, as mentioned, that these patients don't present with vertigo. So if you ask whether they have spinning sensations, they will never say, yes, that's something that I have experienced. So it's always like instability or visual acuity issues, so it's a little bit more different. It's also very debilitating, of course, and the impact on the quality of life, because these people have sort of drunken gait, and that's why people still think that they are drunk. So it can have a lot of impact on them as well, because of the bilateral impairment of this view. So there's specific diagnostic criteria. You can diagnose it based on like caloric examination, based on the rotary chair testing or VHIT. There's all measures that you just read through. I think there's also some debate on that, of course, but now we think that it's a diagnosis we can objectively make with our clinical test, and of course in combination with these chronic symptoms that we do have. And then of course in a static condition where the head is not moving, the symptoms are gone. Because they're not challenging, they're not stimulating their system at that point. So this is something that's introduced in this practice. And this is something very peculiar. It's the superior semicircular canal dehiscence, third mobile window lesion. So that's a very interesting disorder because it produces symptoms that are quite unique. So these are patients that, well, if it's related to the vertigo, it's a little bit more difficult because sometimes it will be spinning vertigo, but more or less it's sometimes more sort of a dizziness or instability that can be chronic or maybe triggered by sounds or pressure or whenever they touch their ear. So this is a little bit more, or if they're straining, then it's something that provokes dizziness because there is a defect of the bone on top of the temporal. So the superior semicircular canal is in fact the highest portion in the temporal bone. And you can tell that in fact there's a small area which is prone to sort of like degenerational or bony loss, in fact. So we see that by increasing age, the risk of having a sort of dehiscence is high. So it's estimated that around 1% of the population has dehiscence, but it's not always symptomatic. This is very important because often we get people that get CT scans can detect whether there's a dehiscence, but they have no symptoms at all. So it's very important that it's something that really needs the combination of the symptoms. You see the confirmation there's a dehiscence or a defect of bone on a CT scan because bone is best imaged that way, and MRI scans cannot see bone, so you cannot immediately diagnose it optimally. And then a combination with some of the more objective tests like the VEM test, OVEM test, CVEM test, where you can have these increased stimulation. So meaning that we have enhanced responses, we have like higher, so thresholds at lower volume sounds that we elicit through the radial or bone connection, or the amplitudes of the noise are increased. And it's also possible to elicit the nystagmus if you just pressure the ear and you have like the winds on the eyes, you can even provoke the nystagmus sometimes. So this is also one of the objective clinical tests that can potentially be used when following these diagnostic criteria in the patient. So this is quite peculiar. And why is it peculiar? Because there's also the other symptoms where you have this allophobia. So these are people that hear their eyeballs move, or hear their eyes blink here, or hear their footsteps very loud. This can be very debilitating. Something also that's very challenging because in the past, probably, this is something that was referred to psychiatry because it was not something that was physiological. And this is something that's very debilitating to the patients. It's also tells about tinnitus, meaning that their heart beat very loudly in a way that it's most very difficult to, in fact, follow a conversation because the heartbeat is so loud. So this is something that can be quite debilitating. And is, in fact, in this case, an option to do surgery to reconstruct or just close out the semicircular canal. But of course, only whenever we have the diagnosis right, and when they have symptoms. If this is one of the asymptomatic cases, of course, we don't do anything. Very important because if we go into the semicircular canal with surgery, there is a 2.5% chance that we lose some hearing level, so sensory neural hearing loss. So this is, of course, very important, and we have to just present it to the patient, and they have to decide whether to opt for this kind of treatment. because it's not life-threatening. It's a functional disorder. You can read about how it's caused. There's some papers that you can read afterwards. So I think we saw some of the disorders, and of course, it looks like, well, probably with these disorders, you can have 4 in 5 of patients, you will have some diagnosis. So you don't need to know a lot on vestibular medicine to just go and have a good practice. But of course, it can be quite challenging because the patient will present and is unable to explain whatever is relevant at that stage. So there's different systems that you can use, and we have the system that was at some stage presented by Munich, trying to go down to these syndromes. It's like 5 syndromes you can use. It's very similar to the things we've seen. Some of it is paroxysmal, so these are the attacks, but it's positional, so triggered by head movements. Can be spontaneous attacks. The sustained, that's the acute vestibular syndrome. So it's quite similar. There's another option where you do some sort of triage. So if you are in emergency care, emergency room, you really want to know whether, okay, is this something life-threatening? Is there like electrolyte abnormalities? Is there like CO intoxication, carbon monoxide? That's still possible. If there's any drug-induced symptoms, because in fact, whenever these patients present with dizziness in the emergency room, well, the majority is not the balance system. It's other kinds of etiologies. So you want to first make some kind of workup to make sure that dangerous causes are excluded. And then, of course, you go to the next step, trying to narrow down whether this is something that you can identify the pathophysiology as early as possible, and then provide, of course, the best management. For the GP level, this is work from the Netherlands, I think it's Amsterdam. So these kinds of systems are introduced more and more in the GP system, where they have these nomenclatures, so the workup and communication of vestibular symptoms, that is more and more used. Well, that's what they present, so I'm not sure whether Raymond will concur that they are in fact using it. But they now know nowadays that you can use like the HINT testing, that's the testing to differentiate between stroke and if it's a unilateral vestibular issue, and also that the Dixalback maneuver and Prima maneuvers are things that as a GP you would be able to do if you know how to interpret this kind of maneuvers. So I think that there are some movements in the approaches in the different care lines that we've seen the last few years. So it all comes down to asking the right questions when you are facing a patient. And often you don't have time to explain everything because it might be not relevant, whatever they are mentioning to you. So often we have to direct the questioning, so we identify these syndromes. It's very important. If we want to narrow down, then we need to just ask them, is it something that's episodic? Is it triggered? Is it something that lasts for seconds, minutes, hours? These are things that they don't think of. So we have to really do some directional questioning to the patient, making also sure that we use the same nomenclature. So as physicians, that if we use vertigo, we use dizziness, there's some kind of agreement on that we are using the same kind of language. It is something different from postural instability, for instance. So this is very important, and this is also work that has been done by the Society very early, and which is very important to the field. And of course, what happens during the spell, if it's episodic, what happens during the spell, or what happens between the spells. This is also very important because there might be some issues in between these attacks, which might lead you to another diagnosis. When it started yesterday, this morning, this night, or maybe 10 years ago, this is of course very important, that whether there was any trauma, whether any drugs, it's like systemic antibiotics or glycosides. I don't think they're not used that often, although be surprised that still for like pediatric oncology, aminoglycosides are given routinely to in fact reduce the risk of any kind of infection. So they get cisplatin, which is also toxic, and amikine, like aminoglycosides. They are not always aware of the impact on not only hearing levels, but also on the vestibular function, which is a little bit more challenging in these children. And very important in the questioning is that it's really unreliable. So we want to differentiate between vertigo or dizziness as a physician. But the problem is that the patient cannot really define their own symptoms. So this was a study where they in fact asked the patient how to describe their symptoms, but 6 minutes later they just called it another one. So they called it a non-spinning vertigo. A few minutes later they checked that in fact they had spinning vertigo. So the problem is that they're not really accurate. So we really go down to the duration of dizziness, the triggers. They are really clear to the patient and consistent. So we use them a lot more than in fact the description of the patient. We talked about, patient we talked about, and these are like the different histories that we see in the Meniere's disease, but we've discussed that, and vestibular migraine, which is important, which will be discussed, of course. This is something that's really differential diagnosis with Meniere's disease. It can be quite challenging. Also, there's a lot of overlap between Meniere's disease and vestibular migraine. If the patients have both, then it's going to be a challenge because you need to be aware what's the active condition, so you can treat the active condition. This can take some time, but after a while, the patient knows which is the active condition, and they can tell you, well, my migraine is going up, so you need me to treat that one, or the other way around. Also, the acute vestibular. So this is the way that we actually want to be a little bit more visual, and just while you're doing the history taking, in your mind, you're already making a diagnostic landscape, trying to narrow down and just go to direct your questioning towards this kind of disorder. You narrow down the list until you have the correct diagnosis. You can also interpret it differently, so you can just visually imagine, okay, this is the patient, these are the spells. It's a way to, in fact, show it to our patients as well. But of course, this is not the clinical reality. The reality is that there's a huge amount of overlap, and that if you, in fact, really question the patient, it might be a little bit more like this. So you have the patient coming in, I'm presenting with dizziness. But then if you do the questioning, it turns out that they have no Meniere's disease. They have their spells. And in between spells, you have some kind of other type of disease, which might be related then to vestibular migraine. So they have two active conditions. But you will not know whether if the patient comes in and you think, well, it's a no Meniere's disease patient, they have vertigo again. Well, let's try to increase the medication or do any kind of surgery on the patient. But the patient will not improve because it has a second condition that is also activated, maybe by the Meniere's disease. Well, we don't know yet. So this is very important. Also, after acute vestibular syndrome, you can have these chronic symptoms. So it really depends on at what stage, at what time you do see the patient. And also, you can have BBPV in a known Meniere's disease patient. So this is very important. If the patient tells you, well, it's different from Meniere's disease attacks, then you have to do the questioning again. You don't have to think, well, it might have been a diagnosed patient in the past. It doesn't mean that if you see them back after 5 years, it might be something completely different. It is very important, as mentioned, if you give medication, so drugs, prescribed drugs, then treats both sides. This is something we also have to talk to our patients on. What are the side effects? So you have to balance the effectiveness of the medication to respect to the side effects. Of course, it's the cost, but for medication, it's not that bad. For surgery, of course, there's an additional part where you have to discuss the potential complications of this kind of surgery. So this is very important. And I do have to say that at this stage, for any kind of management of peripheral vestibular disorders, there have been some Cochrane analyses in the last few months published, and I don't want to spoil this lecture, but there's no evidence for whatever myself doing. But there's no evidence at all for what we are offering to our patients. So this is a huge problem. And the problem probably is that in the reporting of these clinical studies, there might be an issue that we don't find the right outcome measure. That's one item. or we don't correctly diagnose them. And there's a huge placebo effect. So up to 70% of placebo effect. And this makes it really hard to have an active drug really demonstrating that it's working. So it's not covered in this consortium, but I think there's still a lot of work that we need to do. And of course, I just want to show you this trauma. See them in all different sites. But of course, this is what the patients are afraid of. And of course, the MRI scan to just exclude it. But yeah, the chances of having this with vertigo is pretty small, so it's around 5%. So it's not a huge risk. It can be quite challenging because it often has no symptoms at all. It's just sheer luck that someone does an environment headache, which is not a good indication probably, but just diagnosing by accident. In this graph, so these were around 500 tumors that we followed in the hospital. And you see that the giant ones, so the ones that we saw that were really quite obvious, 1/3 of them all. So that's the issue. So these patients have virtually no symptoms at all. So this is something we have to really take care of. So with that, thank you.